We're live.
Okay, we are live. This is Senate Finance on February 16th. And I apologize for the late start. The Economic Development and Housing Committee did get out the housing bill and I called back over the lunch hour to vote and work out the final case. So we are here and thank you everyone for altering your schedules. Okay, we are going to start with S 230, and that is the Medicare Advantage bill. And our first speaker is Dr. Betty Keller. And Dr. Keller, welcome. And just introduce yourself and who you represent, if anyone, for the record, and then the floor is yours.
Thank you so much, Chair Cummings. I'm Betty Keller, Dr. Betty Keller from St. Johnsbury, Vermont. I'm president of the Vermont Physicians for National Health Program. And so I represent that organization, and I'll share when I'm sharing my personal opinions in the discussion if it's not something that's been approved by the board. But we thank you very much for this opportunity to speak with you. We do have a huge concern about privatization of Medicare. Our organization is Physicians for National Health Program, seeking to have everyone either on a Medicare for all type of program or on a more like a VA for all program. Either one is better than what we have right now, and wanting to make healthcare accessible and affordable. And as you know, I'm sure we don't have a lot of we don't have as much educating to do of the general public in Vermont as many other states do, and although we have to start again because it's been a while, and we don't have to work on convincing our members of Congress. So we're more focused right now on educating the next generation with a summer internship that we do, and on looking at how we can improve access and affordability in the state and protect the publicly funded system that we do have until such time that there is a national program. And so that's why we're very happy to have been invited to speak with you on S20, and thank you for your work to try to protect Medicare beneficiaries. So thank you for that. So I was listening with some of your to some of the testimony that you've taken, and it's become clear to me that there are a few questions that have not been answered for you. And so more general questions, not that are important to S30 for you having some basic understanding of Medicare Advantage. And so although some of this will sound like rehash to you, I would really like to share an overview of Medicare and how Medicare Advantage works. And so so I'd like to share my screen now.
Okay,
Oops, it's disabled.
figure that.
Nope, not yet.
Be good.
Great.
Okay, share your screen.
Thank you. So I need to make sure I'm grabbing the right one. This one, okay.
Okay.
And so is that taking the full screen for you now?
Yes, that works. That's perfect.
Great, thank you. And so first disclosure is that I absolutely have a financial interest in Medicare, and so do every one of you in the room, and so does everyone in America. We want this to be around not just to take care of us, but to take care of our children and grandchildren, unless we have been able to figure out how to get healthcare for all. And so what is traditional Medicare? That is Part A and Part B. Part A being the hospital, nursing home, hospice care. There's no premiums on that. You've been paying into the system. You or your spouse have been paying into that system. Very few people have to pay a premium. It's tiny. And then you pay a deductible and co-insurance on that. Part B is the outpatient care, and that is around $170 a month. So if you have a couple, that's a large chunk of your monthly income. Is there anything else covered by Medicare? So sometimes, you have all these different parts people talk about. Part D does have federal subsidies to help pay for private coverage for prescriptions. That's all pretty opaque. You can be looking over all the information about Part D drugs and not have a sense of like, how can they get away with selling a plan for 50 cents a month? What? Doesn't make any sense. Well, because you can't tell if there's federal subsidies there. If you are low income, you can actually get extra help for an extra subsidy. On the traditional Medicare, there's no vision, dental, or hearing. Of course, if you have cataracts or glaucoma, that's a medical condition and that is covered. But for eyeglasses and things, you do not have coverage under traditional Medicare. Now you saw that there's coinsurance with the traditional Medicare, and if you have to pay 20% for a very large expenditure, that ends up being a very large amount of money. And so Medigap is a private commercial supplemental insurance to give you an out-of-pocket cap and help with the other expenses. Sometimes instead of Medigap, you may have coverage from a former employer or union or from Medicaid. And they have to cover all that traditional Medicare Parts A and B cover, but are not allowed to cover anything else because they want you to be able to, the federal government, when they're regulating these things, wants to make sure that you can compare apples to apples when you're comparing plans. Now, this is what we want to talk about today is what is Medicare Advantage? This is a program that changed the way that Medicare pays for seniors care. This program does have to cover is supposed to have to cover the care that is required to be covered in Medicare Parts A and B. They can choose to also pay for prescriptions. So that would be that Part D thing that we talked about, dental, vision, or hearing. They have to pay for their overhead, and they are also able to pay for profit, which can be up to 15%. And now in traditional Medicare, you see the doctor bills Medicare, and Medicare pays them directly. In Medicare Advantage, there is this middleman, and they call it managed care. So you might say that's managed money, but we'll call it managed care here. So they're allowed to keep as profit and overhead what they don't spend on the medical services. So those things, if they have to spend on medical services, those are called medical losses. They don't actually want to lose that money. They don't actually want to provide care. They want to have profit. So that is a dangerous incentive to ration and restrict seniors' care, which does not exist in the traditional Medicare program. And I heard a couple of you, especially I remember the chair asking, how do Medicare Advantage plans make money? If they have to pay for A and B and they pay something else, where do they cut their corners? So there are two ways this business model works. One is to minimize the revenue spent on patient care. And how do you do that if you're still covering Parts A and B? And then the other is to maximize the revenue. So let's talk about minimizing the expenditures. The primary method used to be to seek patients that don't use a lot of services. So they would advertise in, fitness clubs, for instance, figuring that these people are out there getting exercise. And more recently, though, they've had another strategy, but on this one, for limiting the care available for expensive conditions so that sicker patients will leave, they have to cover a product, but they don't have to offer the best one. So they can choose to not cover the hospitals that are needed for the most expensive care. So for instance, a highly reputed cancer hospital may not be in their networks, or a highly reputed specialist in a particular field may not be in their network. The other thing is that not only might they choose to not cover expensive drugs, but they might choose to not cover cheap drugs that are needed by expensive patients. Then the other thing that is huge that I'm thinking you folks may not know about or may not understand is maximizing the revenue from Medicare. They can upcode, making seniors look sicker than they are. And in that way, they can get higher monthly payments from Medicare, regardless of how much the care the patients actually receive. So that started in 2006 when the plans were complaining that, well, some of these sick people cost way more to take care of them. And so Medicare agreed to develop this thing called diagnostic codes for chronic illnesses, and would pay these Medicare Advantage plans based on the that coding. So here would be an example of a 76-year-old female with the typical coding that was before 2006, or by people who aren't trying to game the system. And so she has a baseline score for just being 76 years old and a female of 0.45. Obesity, they didn't actually give her extra points because they didn't say, how bad it was. Diabetes is 0.104 for type 2 diabetes. Major depression, they only gave a 0. And you can see on down the line. So the final cost per for this patient for the year is going to be $9,000. Now, I'd like you to take a look at this upcoded version. After 2006, over the years, they've been able to fine tune their upcoding skills and software and training. And this same person, still 76-year-old female, but now they're calling her morbidly obese. And morbidly obese doesn't actually have to be that huge, but it's 0.273 now. They're calling the type 2 diabetes with retinopathy. So they looked in the back of their eyes with their ophthalmoscope, and they saw something that they don't actually have to take care of right now, but they can charge 0.318 anyway. I'm not sure what would be more mild for major depression than a single episode of mild major depression, but somehow or other, they're able to get 0.395 over that instead of 0 and on down the road. So you see the total risk score instead of 1.03 came out to 3.63. And the annual payment plan to the Medicare Advantage plan was $32,000. So with that amount of money, you can see that they don't have to only go after the sick, only have to go after the healthy people now. They can still make money. Now, there's been a lot of penetration of the market with Medicare Advantage, but there are people who still choose that they want to not be restricted by narrow networks, and they are choosing Medicare, traditional Medicare and paying for a Medigap. And so Wall Street's wanting to know how to get profit from those people who chose to stay on traditional Medicare. That is a talk for another day, but we should be proactive because it's much easier to prevent something than to get rid of it, as you folks have noted before. So to go specifically to the bill that we're talking about today. Oh, actually, let me just stop sharing screen and see. Did folks have any questions about the upcoding or anything else I've just talked about?
Any questions, committee? No, I think we're fine.
Okay, great. Thank you. So I will go ahead and share my screen again. And so I wanted, whoops, I might be in the wrong slideshow. Hold on. So I think I need to look at it and find the right one here. So I wanted to go over 230 with you section by section. And I was going to start at the end of it with section 7. And so right now I'm not figuring out how to get out of my full screen. How do I get out of this? I'm sorry, there we are. Okay, so.
Okay, Betty, we have 2 other witnesses.
They're all together.
They're all together, so you've got until 2 o'clock. Just the longer you go, the less time I have for your fellow member. But
right.
That, that's, Dr. Malik has spoken to us earlier this week. So he might be the sacrificial lamb.
Okay, very good. So just getting back to the right slide set here. I'm not sure when I turned off my screen and came back, I lost it there. So what I wanted to talk with you about though is section 7. on that, and I will. Okay. So, so in section 7, toward the end, it says, as used in this subdivision, the term Medicare products, let me put this back in the slideshow version so it's bigger print for you to see. The term Medicare products includes Medicare Part A, Part B, Part C, also known as Medicare Advantage, and Part D. And on the Medicare.gov website, on the illegal practices page, it actually says it's illegal if anyone tries to claim that a Medigap policy is part of the Medicare program or any other federal program. Medigap is a private health insurance. And even if it didn't say that it was illegal to call it a Medicare program, I would encourage us to not reinforce that false impression on people and not put it into our state law that it is a product. So I would encourage you to instead say, as used in this subdivision 8, the term Medicare products includes Medicare Part A and Medicare Part B. And then choose a different phrase, and I'm using here Medicare related commercial insurance products. So then you would have a Part C. As used in this subdivision 8, the term Medicare related commercial insurance products includes Medicare Part C, also known as Medicare Advantage, Medicare Part D, and the Medicare supplement plans. Also in that, was there anything anybody want to say about that?
No.
Okay. If you change that language, then you need to go back to section 7 on pages 7 to 8. And in that place, you would say, use an appointment that was made to discuss Medicare related commercial insurance products, or whatever phrase you chose to use instead of just saying Medicare and products. So there are 2 places that Medicare products would need to be changed. In addition, I thought that this sentence was a little confusing. Like I had to read it a few times to get the gist of it. So I'm wondering if you if your legal counsel feels it would still be saying the same thing. I know legalese has its own ways, but where I have the asterisks, you might say instead or in addition. So to solicit tales.
I'm losing the train here. What would you like us to change?
To add the words instead or in addition where those asterisks are.
In addition.
So for instance, when this person shows up for an appointment to sell you a product, they can't also or instead solicit sales of any other insurance products.
We've been told we cannot limit who can sell Medicare Advantage. That we can't, the bill calls for brokers not to be paid a commission. We've been told that federal law preempts that. In fact, federal law preempts us doing almost anything.
Right. There are a lot of challenges, but I think that's in section 5 that 5 or 6 that was talking about. I'm still talking about section 7 here. So maybe you have to scratch this whole section, but if this language we're saying here, these are the 2 places where you would need to change from Medicare products to Medicare related and commercial insurance. And this one in section 7 was saying that you could not sell, purchase, or negotiate the purchase of a product to an individual who's enrolled in Medicaid or in Medicare savings plan. So if you cannot do anything, then that's going to come out of the law. But I would be really surprised if you can't do this, or maybe even it's already in federal law, because I know that you cannot do these things. You can't sell a Medigap plan to somebody who's already in Medicaid or Medicare savings. So that might already be.
I haven't heard we can't do this.
And then this is in part 5. And you've been told that right now that there's nothing that you can do. However, we support keeping this in hopes that HR 732 at the federal level, the Save Medicare Act, if that were passed, then you would have this already ready to go. And this bill, the way it's written now, says all measures not prohibited under federal law. So there's not a problem with passing it the way it is. But then you would be ready. And okay, this is the one. This is the one in actually in part 5. I'm sorry. So you were correct earlier that this is the one where you we think it's probably already that it is probably legal and would be federal, or perhaps already be federal law, that you can't sell to somebody who's in Medicaid or Medicare savings. Okay, thank you. And that's the end of what I wanted to share on the screen.
Okay.
So in our conversations within our chapter, and we do have a range of opinions, but in section 1, we support not allowing Medicare Advantage to be offered to retirees. One of your folks, one of the people who've given testimony, talked about the penetration and that there would be a bigger problem if there were bigger penetration. And so every time you make it easier for people to be put on these Medicare Advantage plans, you're increasing that risk. We would encourage you to reach out to states that self-insure, like Massachusetts, and learn from and or collaborate with them to facilitate cost control efforts. So for instance, you could have a much larger risk pool and create a plan so Massachusetts has, for their state employees, they have a plan that covers, that has several different Medigap style plans, but they have also added as a separate thing, because with Medigap, you can't actually change the initial product, but you can also sell them vision or dental at the same time. So they've negotiated really good contracts for those. So they actually come out close to what the negotiated Medicare Advantage program would have been if the Medicare Advantage program that was negotiated actually met the quality of the other ones. So that's the thing, is like the Medicare Advantage will cost more the higher quality you require into it with your negotiations, but less than if you were trying to do that as an individual.
Okay. But this bill forbids state employees from ever being involved in a Medicare Advantage.
So, but where we're talking about Medigap, right?
Okay.
So I have 2 colleagues here, and after I finish speaking, Eduardo Sequeira could speak a little bit about the Massachusetts one if you had questions on that, perhaps.
Okay.
So in sections 2 and 3, our organization does not have expertise in union contract negotiations. So we're not going to take a stand on that. Sounds like a good idea, but I'm not any more expert than anybody else on that. And section 4, so our organization actually does not have a position on section 4, the most controversial part, because we have a difference of opinion. You know, it's so expensive for folks to pay the $170 a month for the first, the part B, and then also pay for the Medigap. So we feel for those who are struggling to do that. And if they went on Medicare Advantage because they couldn't afford the other, and then they got sicker, we can appreciate, the humanity of wanting to help those folks. On the other hand, we're very concerned about the cost that will, how expensive the Medigap will get if the higher risk people have all, been headed over there, if there's an unlimited opportunity to move between the plans. However, we do, and Marvin had mentioned this the other day on Wednesday, the idea of having a one-time opportunity to move back. And then the other thing, which, and I will say that we didn't discuss this, I was just thinking of it more recently. So this is a personal opinion. Those people who have been put on a Medicare Advantage plan through their retirement benefit programs and didn't actually have a choice unless they just turned down all the benefits that they had earned, well, all the health insurance benefits that they had earned, that they should be able to move freely back on if their health concern is not being met on the plan that they were forced into.
Okay, I think what we've heard is that if people can just come off Medicare Advantage and come in on the same terms that I came in with when I turned 65, that if you get all those people with diseases that they don't like the coverage on Medicare Advantage, that we're going into adverse selection, and we could end up having Medigap be priced out of the range of even more people. We do know in this state that there is a guaranteed issue for Medigap. It's 20% higher than the regular, but there is an option here for people that want to come back. They can get Medigap. But I've been paying to get my teeth and my eyes done for 20 years. And I can't switch over there now and say, now that I've got cataracts, I want you to cover it. They wouldn't take me. So we've got to, we're balancing the cost and the prohibitiveness of the cost against wanting to let everybody come back in. And states with open enrollment, we've heard, have higher Medigap costs than we do.
Right. And so I was speaking specifically about those who did not have a choice. The people who, when they turned 65, just looked at the prices of the two and decided to go with the cheaper one, that's one thing. If they had been on a retirement plan that promised them a bigger benefit, and to get their benefit, they had to go on the Medicare Advantage plan, that didn't seem fair to make them pay that price if they had already negotiated for that earlier.
Okay, we haven't heard testimony that people are being forced. We have heard that people go under Medicare Advantage because they have zero pay options. And for many people trying to retire on Social Security, they can't afford anything. I know more than one person who's living on Medicare, straight Medicare, which means it risk of really high premiums or high medical expenses. So there
Right.
is
So people, for instance, in New York City, there was a big thing with the unions there. Here in Vermont, we had a big deal with the state employees potentially being put on it. Teachers have been put on it. So there are groups of retirees who are being forced onto it.
okay,
So the other thing I wanted to mention is that in that section 5 that there's not a lot that the state can do. We would really like to see an educational campaign about Medicare Advantage abuses, and I believe that Emily Brown spoke about that a little bit. I'm not sure how much budget how much you'd need to put in the budget for that, but we would also like the state to look at sending a unified statement to the Health and Human Services Secretary Becerra and to President Biden and to Vermont's federal delegation, requesting strong action to curb these things, to prosecute the abuses, those sorts of things. And I know that our congressional delegation wants to do these sorts of things. So I would encourage us to reach beyond that and actually be reaching out to the to CMS, for instance. So it's really distressing that there's so much, the revolving door between government and corporate interests. But you look and see who is actually running this CMMI, that the Centers for Medicare and Medicaid Services Innovation Center. And it's somebody who was in the insurance industry before and who is not dedicated to protecting the Medicare beneficiaries. It's somebody who is, motivated to maintain as much private enterprise and opportunity for profit as possible. So I do want to make sure I leave time for my colleagues to also speak. And so Eduardo, would you like to share your thoughts? So this is Eduardo Sequeira. He is an MD, SCD, professor emeritus from University of Massachusetts, Boston, who has recently moved to Chittenden County, and we're very excited to have his expertise. Thank you.
Okay. So
Thank you very much for allowing me to speak to you today. I also listened to previous testimonies, and I believe there are a few issues that we need to explore. Number one, why is it that only Medicare Advantage advertises? Why is it that we don't have a lot more information for the public about the traditional Medicare and also the Medigap plans? It seems to me that the industry decided that the most profitable way of enrolling people is to getting them into Medicare Advantage. And it seems to me that what they suggest to people is that it's a free lunch. In other words, if you get here, you don't pay much, you get more coverage, and life will be good for you. And they don't, of course, have the interest of telling people this is not typically what happens with the majority of folks after 65. Because after 65, even if you don't have serious disease, you're going to get a lot more coverage and need a lot more coverage than typically Medicare Advantage allows. And one of the issues that we know is about the denials of prior authorizations that are growing. And of course, what ends up happening is the insurance companies in this program get the bonus and Medicare get the onus. In other words, they get the profits that Medicare allows them to do. And when the situation gets really expensive, they try to not cover these people and deny service or upcode the services. So this is where the problem really lies. By allowing this to continue, we are actually creating a situation for Medicare that's not sustainable. And we already know that nationally, Medicare is under threat of not having enough funds by 2030, 2040, depending on the assessment that you have. What we can try to do is control the advertising to the extent that the state can, but also support the information so that the consumers can have what we call in medicine informed consent. I don't think the consumers today have informed consent. They are consenting for something that they really do not understand. And as you well know, once you retire, that's when you learn how complicated it is to choose plans. And I would suggest that we need a strong educational campaign that includes not only the issues that Medicare Advantage does not cover, but reinforces what the original Medicare and the Medigap plans are, because there are lots of details that most people are not aware. And we need to improve this or create a situation where the companies that offer the plans, which are the same companies, they have to equally advertise Medicare as well as Advantage, instead of only doing Advantage, which, by the way, I moved here from Massachusetts. It was incredible the amount of advertising that we got between October and December, an enormous amount of advertising, which did not happen in Massachusetts. And part of it is because they do not make the same amount of profits with Medicare Advantage in Massachusetts. Although the penetration is higher, there's a lot more control of what they can do. And I was a union, I am a retired union employee, and the offers that the union allows us is much more comprehensive. The information that we got that allowed us to actually understand it. If we had questions, we self-insure in Massachusetts. It's called the Group Insurance Commission. So the state employees have a lot more control on the products that are offered. And because of that, the choices we have, we can compare the prices from between the different plans without the needs of brokers, because the brokers have a self-interest in promoting Medicare Advantage, because they make more money per enrollee if they promote Medicare Advantage. So we have to do something about that. This is not an equal playing field. In one plan, you get a bonus, the brokers get more money, and the public is not well informed. On the other side, we have owners that will come later in life, sometimes not only too late in life, because I heard the chair talk about 85 years old. It doesn't need to go that far. You may retire at 65, and then at 67, 68, you already need a lot of services that then you're going to hear that people are not going to cover, that insurers are not going to cover. So to summarize my points, I believe we need much better advertising of the original Medicare and Medigaps, as well as the problems that we have with Medicare Advantage. And the other thing is to increase the pool of people that can actually negotiate with these plans, because individually, there's no way individuals can negotiate with the brokers in a fair and equal playing field as we do when we have a large pool, as I have in Massachusetts, that allows me to be part of a pool of 460,000 people that negotiate as a group with insurance companies. Thank you.
Okay. As a former resident, native of Massachusetts, you're a lot bigger than Vermont. There's more people in Boston than there are in the state. So we don't have the magnitude to do that kind of group. Anything, that kind of group, that it's just difficult because we're a very small pool. Okay, Dr. Keller, I'm going back to you. We're down to 5 minutes and I want to let Dr. Malik
I
have
just
it.
wanted to very briefly say that we could do a compact with another state. We could coordinate with another state to get a larger pool. That's all I wanted to say. Marvin?
Yeah, thank you. Thank you very much. I just want to add two things. One is that,
You need to introduce yourself for the record.
I'm sorry.
This is
My name
all.
is Marvin Malik. I am a medical doctor. I've also studied I have a degree in public health policy, public health. And I spent half my career in primary care, internal medicine, and the other half as a hospitalist doing inpatient care. So I guess the 2 points I want to make is that I'm understanding you to have discovered that that apparently the federal government has jurisdiction over advertising by these private plans, and you cannot do anything to force them to change their promotion. But there's nothing in that law that says that you cannot disseminate accurate information to the public. And I think both Dr. Keller and Dr. Sakara are saying that very same thing. So I would like to encourage you in the strongest terms to include something in the bill, a clause that would say that the state will be responsible for putting out accurate information to the public and letting people know it's available. You could come up with denial rates. You could publish the landmark study that was done 2 years ago by the Office of the Inspector General, talking about that 15 or 18% of Medicare Advantage denials were completely inappropriate and not supported by any data, and the like. So that would be the biggest thing I would encourage you to do. The other is that I think the legislature in general, your committee could lead this, should send a letter to Secretary Becerra and to the president, and maybe in coalition with our federal delegation, just letting them know that Medicare Advantage is a very corrupt program, detailing all of that, and letting it out and sending it and disseminating that to the public as well, so that you're on record as pressuring the Medicare program to clean up this corruption and to make Medicare something that is there for people rather than for the benefit of private corporations. I thank you so much for allowing us to testify. Thank you so much. And we're all happy to take questions if you have any.
Any of you know where we could get a copy or access that Inspector General's report?
Yeah, I'll email it to Keisha. I have her email address.
Yeah.
And Shane.
Saying about Metzger, and we'll get that out, we'll get it posted on our website so that anybody that wants to can read that. Okay, thank you for testifying.
So thank you for trying to address Medicare Advantage as best as you can from a state perspective, and I look forward to hearing more about how those prior authorizations can be dealt with in some of the other bills that are in the House right now, 233 and 766, I think. Thank you so much.
Okay, thank you. And we are 2 minutes early, but I think our next witness is here. Same bill as 230. We have Dr. Ada Avdic. And after that, we're gonna have Chris Doherty. So Dr. Avdic, probably massacred your name, Avdic. Just introduce yourself for the record, who you represent, and then the floor is yours.
Thank you so much. My name is Aida Avdic. I am a physician at Brattleboro Memorial Hospital. By training, I am internist and work as hospitalist, so take care of patients who have to stay in a hospital for whatever reason. I have been practicing in the state of Vermont for 12 years. Thank you for this opportunity to speak to you about the impact that Medicare Advantage plans have on Vermont seniors and our community. I have 3 examples to share with you that sort of illustrate different points at which Medicare Advantage plans put seniors at. One is that happened just last week, and it involved denial of payment for end-of-life care for Advantage member. This was an elderly gentleman from the community who wasn't doing well and cared for by his wife. And he presented to the emergency room with a catastrophic intra-abdominal process. Family met with various consultants and ultimately decided to pursue end-of-life care due to significant comorbidity and likely deaths from pursuing aggressive care, including surgical care and whatnot. We cared for the patient through the weekend in hopes of arranging for home hospice transfer. As you know, trying to arrange transitions to home or hospice on the weekend is challenging because of staffing issues and whatnot. The patient died peacefully on Tuesday morning. On Tuesday afternoon, I was notified by my hospital care team that his Advantage Plan program has denied his admission stay, and we're going to burden family and us with not paying for his care. So I had to get on the phone with their medical director and appeal the stay, appeal to pay for this gentleman's end-of-life care and a right to die with dignity. So that's one example. We are having more and more denials about inpatient care or paying for care for Vermonters. We have to constantly argue with the insurance companies and medical directors and call on almost daily to weekly basis to argue for payment of services, both to hospital and to patients. The next example I want to share is delay of care and delay of transfer to or access to subacute care for Vermont seniors. This patient is also an elderly, frail woman who is living in a community by herself with some support. She presented with a bloodstream infection, sepsis, was adequately stabilized and treated, and by standard of care should receive about 2 weeks of intravenous antibiotics. When she was clinically stable, our usual practice is to consider either discharging home to complete course of antibiotics or to a subacute facility for rehabilitation and antibiotics in case they don't have enough supports. Her particular insurance plan dragged their feet, never sent us a confirmation or denial. We tried to submit referrals to multiple facilities. Facilities did not get a response from the insurance company. And ultimately, patients stayed in a hospital for 14 days for her antibiotic course, even though they were ready to transition to an alternative level of care by, let's say, day 4 or 5. This led obviously to prolonged hospital stay, exposure for potential, another infection or other safety measures and issues in a hospital, and not to mention prevented somebody else from getting that bed. The same patient actually is here currently. She had another issue for which she needs subacute care, and her company, again, this time we were a little bit smarter. So we called the company after 2 days of trying to reach a representative. They told us that they contract with a nursing home facility in Lowell, Mass, and a nursing home facility in Nashua, New Hampshire. No Vermont facility will accept this insurance plan because I guess they don't either contract or don't pay for nursing home services in the state of Vermont. So that's another example. A third example, again, goes to similar situation where people are experiencing denial of subacute rehabilitation services. And similar situation, an elderly gentleman presented with pneumonia. He's got some cognitive impairment. He's cared for by his wife. He was treated appropriately and was weaker than usual, wasn't mobilizing as well. Physical therapy thought it would be appropriate to go to subacute rehabilitation to regain some strength so that he can be more successful upon transitioning to home. His company, again, we sent the referrals, no rehab place in Vermont would accept him, and we contacted some, and they unofficially told us that this company, that this particular Medicare Advantage plan, does not pay them ever, and they no longer accept patients with that particular Medicare Advantage plan.
Okay, so we've got people that, their coverage sends them to Massachusetts or New Hampshire, which essentially separates them from their family and their friends, because that's a long drive if your friends are 80 years old. Yeah, your family works. Or we have people who can't get into nursing homes because of the pay rates of Advantage.
That-
Okay, well, we've heard that, yes, that they are paying a large, that they're a big problem for nursing homes just being able to stay open and cover their costs. So what happens to the lady who can't get into a nursing home?
So
Is
she's still here. She's still here. I can't send her home in an unsafe environment. She is receiving custodial care in an acute care hospital. I'm sure we will not get paid for any of this care.
And we've heard that from Dr. Malik, that if the physician says she doesn't need to be in the hospital, they stop paying you. But we know we have a problem with getting elderly people transferred to nursing homes, but that's mostly dementia issues. So you've got somebody sitting there, you ethically can't release her, and you're not getting paid for your time. Okay. All right.
These are
I
the
don't know
examples
what
I
we're
wanted
gonna
to share. Go ahead. I'm sorry.
I think what you're sensing is frustration. The feds preempt us from doing almost anything. And, yeah, our hospitals are always have issues with funding and staying afloat. And now we've got people sitting there taking up a bed that somebody who is acutely ill could use. And nobody's getting paid. Okay.
And I do want to mention this, constant need to sort of justify stay. So I spend a lot of my job these days is calling medical director of whatever Advantage plan to argue to pay for admission. And I will tell you that 80 to 90% of the time, I can argue for them to pay for the admission, which means that they are inappropriately denying payment and making extra obstacles for hospitals, for physicians to an extra sort of work on all of us and stress to fight for our patients, to A, get paid ourselves, B, for patient not to be stuck with a hospital bill, because that's what ultimately happens. I will survive, hospital will maybe survive, but the family and patient end up getting stuck with this bill if the insurance is not paying for it. So
They have insurance. Okay. I'm just wondering. I need a lawyer. What we can do, I mean, this is frustrating. I don't know. It was suggested earlier that we could join a compact with Massachusetts, maybe another state. I guess they have more clout than we do, but we'll look into it.
I think what we can maybe do, and I don't know how, but we can't obviously ban federal programs or federally funded insurers, but they all have different levels of these Medicare Advantage plans. I'm using quotations here. I think there might be a way to require for them, if they're going to operate in the state of Vermont, to contract with Vermont subacute care facilities or to contract with Vermont, institutions, so that services are paid in the state of Vermont, And if they're not gonna do that, maybe that particular Advantage plan, I don't want to name names, but I'm happy to. Maybe that plan should not operate in the state of Vermont, but a different plan by the same insurer that offers some of these benefits could.
Okay. All right, committee, any questions? Not seeing any. So I've got Chris Doherty next.
Thank you for your time.
Thank you.
Thank you.
And Chris, just introduce yourself for the record and the floor is yours.
Oh, thank you. Hi, I'm Chris Doherty. I am the President and Chief Executive Officer of Brattleboro Memorial Hospital. I had the great honor and privilege of working with Dr. Avdich, and I'll probably repeat a lot of what she's said. I will tell you that I'm going to speak very generally about the issues that we see with Medicare Advantage. As Dr. Avdich was saying, there are differences between the different plans. And so unfortunately, what I'll be saying is sort of a broad brush, I hate to say sort of indictment of the Medicare Advantage plans, but these are the problems we commonly see. And when I say we, yes, we see it here at Brattleboro Memorial Hospital, but then I think if you ask any of the systems or beneficiaries throughout the state of Vermont, they're going to tell you the same thing. And if you look nationally, you'd see a very common theme. And I heard Dr. Avdich talking about the issue of long-term care, and that is probably, in my mind, Dr. Avdich, the greatest complaint and concern that we see. A lot of the Medicare Advantage plans have zero long-term care coverage, even including custodial care, no coverage there. If they do have any coverage at all, it's for such a short period of time that you end up having to the physicians have to keep going back to try and get additional authorizations to stay. And it is very alarming. It becomes more alarming as our population, as you all know, is aging very rapidly here. Where we are, where Dr. Avdich and I work, we're the oldest county in all of Vermont. Windham County has the oldest population, which means that we have a lot of individuals, first of all, that are Medicare beneficiaries, and then secondly, that have multiple chronic illnesses that need lots of care. And the issues that we find with Medicare Advantage not being able to take care of long-term care is very problematic for us. The state, I believe on March 18th, will be applying or will be filling out an application to the federal government, CMMI, a component of the Centers for Medicaid and Medicare Services, to put Vermont into a global budgeting program. I'm not here to talk against global budgeting, but I can tell you what doesn't work in global budgeting is exactly the situation that Dr. Avdich was describing. Having a person in the hospital that has no need for hospital care, that's a cost. We still have to staff. We still have to do everything. We have to feed. We have to do all these things. When you're getting paid on a fixed income, as global budgeting is, this will be devastating to a hospital. A patient or two like this will really sway any opportunity we have to keep our heads above water in global budgeting. Some of the other things that we commonly see outside of the long-term care coverage, Medicare Advantage plans, unlike traditional Medicare, can actually change their coverage and benefits annually. And that really can sometimes lead to a great deal of uncertainty for beneficiaries. They may have had medications that were covered by their plan one year. The plan changes its coverage the following year, and then they're kind of left out there saying, I started this regimen and now this is out-of-pocket cost to me. Doesn't happen with traditional Medicare, but it can happen with Medicare Advantage. Dr. Avdich was actually doing a really nice job of describing what a lot of people call the prior authorization runaround. This has been and the federal government has actually tried to take action against Medicare Advantage plans because they make you do so much to try and get things authorized for care. And this leads to delays in needed care. It could be procedures, it could be medications. There are some, and I emphasize some, Medicare Advantage plans that, believe it or not, require prior authorization for preventative care, which is kind of defeats the whole purpose of having insurance if you're getting denied for preventative care. And this is something that has been documented quite a bit nationally about the prior authorization, and then the high level of denials, as Dr. Avdich also referred to, has been very problematic. So even after you've gotten a prior authorization, performed the care that was authorized, we still get denials and have to go and contest those denials. What's interesting is when you go and contest those denials, Dr. Avdich may be able to get to a medical director, but when our staff in billing tries to contest, they're getting a robot. Everything is being cleared by artificial intelligence. And so it's become another challenge of trying to get through to a live person that can actually listen to the concerns instead of really just giving you a routine, this is denied, this is denied. Another concern that we hear from beneficiaries is that some of the Medicare Advantage plans have very high out-of-pocket costs, especially for premiums, deductibles, co-payments, and co-insurance. These out-of-pocket costs vary significantly by plan, and some of the Medicare Advantage plans have higher out-of-pocket costs than traditional Medicare. I think maybe Dr. Avdich had mentioned that another issue is, and I believe it's in Senator Harrison's proposal, has to do with the advertising of the plans. It's what we hear from our beneficiaries is that it's overwhelming. And for many who are challenged with health literacy, trying to compare the overwhelming amount of Medicare Advantage plans and trying to make the right choice of a plan for the specific needs that a person may have can be overwhelming. And then you find people stuck with a Medicare Advantage plan that really isn't accommodating their needs. We also do have some issues with Medicare Advantage plans. Each of them can create their own formularies in terms of what prescription medications are on those formularies. And a lot of those have some very limited and restricted formularies. Speaking of limited and restricted, because all the Medicare Advantage plans are voluntary for physicians to participate in, some of them have very limited and restrictive networks. And then that means that a person who may need, let's say, a rheumatologist and there's none in the network, that becomes an out-of-network referral, which again becomes a very high out-of-pocket cost to a patient. And that is concerning. I think that was the only other thing that does happen is that if you have switched out of traditional Medicare, we've heard, and into a Medicare Advantage plan, and you decide you want to go back into traditional Medicare, that it's very difficult to do so. We've heard from some beneficiaries, and that we've also heard that you also lose your Medigap, the supplemental component of Medicare, and that it's very hard to get that back. I hate to say these are really broad brushed concerns, but this is what we hear from our beneficiaries. And again, we deal with a lot of patients that are on Medicare because of the age of our community, and I think are confused by the difference between traditional Medicare and what Medicare Advantage is. And I think that leads to some optimal coverage for some of our beneficiaries in this community.
Okay. Thank you. We're working on this. It's frustrating how much we can't touch.
We appreciate that. And again, we applaud you. And I think we just want to work as an ecosystem for healthcare. And we all need to be pulling towards the same goal, and that's to keep people as healthy as possible.
We'll have to see if we could get some money. I know DFR is working on doing an informational for people right when they hit that 65 and you gotta make a decision fast. And yeah, I'd like to get my dental and my eyes, because those are the things you're dealing with at 65. And you don't really like to think about needing to go to, it probably isn't on anybody's list. So that may be the most we can do, but we'll work on it.
We really appreciate it. If we can help in any way, we're here to help.
Okay, thank you.
Thank you.
I wonder if we could require, we'll have to get back to DFR, if we could require that you have a specialist, or at least a nursing home or two in the state that's on your list. No,
I think
I am filling in.
federal regulation.
That's crazy. You gotta go to Lowell, Mass to find a nursing home.
Yeah.
I mean.
Yeah.
That's.
Can I join you for a minute?
You can join us for a minute. We have about 1 minute. We only have Julia from 2:30 to 2:45. I'd love to get 8:50 out of here today, but we're all getting more emails. The eyes of the world are on us.
Good afternoon. Thanks for letting me come back to the seat. Mike Fisher, healthcare advocate. I think that there are pieces of this bill that I would continue to advocate for, which I don't think the committee will move. Particularly I think there are pieces of this bill that you can move. And it might not be as much as an advocate like me is going to push for, but I think that there's some steps you can take. And to identify in particular the advertising piece, asking DFR to do what's regulated, what's allowable. And I think we are understanding the prohibition on sale to people on Medicaid and MSP. And I've double checked that that's allowable, but if it is, I think that's a
Yeah.
good
No
move.
one has told us yet it isn't.
I'll just make a last plug, even though I know I'm not gonna get it. I think DFR, I think Emily Brown said very clearly to you last week that there is adverse selection going on here, but it is the adverse selection of Part C plans pulling healthcare out of a traditional Medicare that is causing the increase in Medigap rates.
Yes.
Not the people moving from, not in those states that allow it, people moving back to traditional Medicare. That's what it was Oliver Wyman who did the report for them in the afternoon United report. So
What is on our website.
so at any rate, I think I guess what I want to put a plug in for is even if you're not able to do the whole bill, there are pieces of the bill that make sense. Oh, and I will mention again, it's a good thing that Blue Cross offers a guaranteed issue plan for people who don't get in the initial enrollment period. 20 to 50% more expensive does not fix the problem for those
Yeah.
people who
We don't have them.
who want to move back. Is prohibitively expensive for many. But it's a good thing nonetheless. And I understood there to be broad support for putting that in the statute. So that would be another thing I would contemplate adding.
Okay.
So
Again, we're balancing it against the cost of.
in this case, what I'm talking about is putting into statute what's already happening and just to assure that it keeps happening. But I really just wanted to come back to the table and say, I know you've heard a lot of different opinions. I think there's a core of this bill, there's a few sections, but still that can reasonably be moved forward.
Okay. think we would like to, I think we probably would like to move further and more.
Okay.
Given the testimony. We just are preempted in many areas. Okay, committee, we have next on the agenda 199, which is the new language we saw yesterday. Is Maria coming down to this?
So we wanted Maria on H850s, but she can only be here 2:30, 2:45, so I was figuring
Oh.
I'd swap those.
Okay, well, yeah, if Julia can come down now.
Yeah, I mean, she'll be here in 5.
Okay, so Julia will be here. And then the other one is we're voting out. We got the treasurer language yesterday, we have to vote to amend, and then we vote. The bill, I hope. And then we get on to 850. And writing angels here. You get it, by the notes that are going out, I'm saying you're starting to get what I've been getting for over a week. One of them, so the eyes of the world are on you, vote for, limiting cost. It was suggested that we put on a 10% cap. But I'm gonna ask Julia, but 10% cap of spending as a whole, or if it's spending per pupil, there's different ways you weight that. And if you capped it more the spending per pupil, Stowe would not be as pleased with the outcomes. Because it's your cost per pupil that is going up in a lot of cases, not your actual spending.
How is pupil measured in that? What you just described?
I do not know, sir, how is pupil measured?
I know, but in some cases, pupils are measured,
Wait,
people are, and reduced, when you lose students, you don't lose as many as you actually lose. It's
True.
delayed for,
but we got rid of the phantom students.
they go into private schools now.
Ones that are leaving. I don't know if we have a number, but there's a lot of private schools.
Out of state.
Everybody is here. We only can get Maria at 2:45 or 2:30. When can we get Maria?
I don't know, I didn't realize that she needed to be here, she presented the draft.
She should bring us the amendment. So we have the amendment?
Wasn't that yesterday?
Yes.
Maybe?
Okay, so if we have a written copy of the amendment, then we can do that. So you might as well take the front seat and so.
All right.
Good. Okay, so we can get that. We are all receiving emails that say we've got to stop spending, people can't do the caps. It was suggested yesterday that we cap spending at 10%. And I know we were talking, there's different ways of counting spending. It's your per pupil or your overall. Can you kind of explain that to the committee, how capping your overall spending isn't the same thing, or the two, 3, 4 ways to do that?
Sure. So for the record, I'm Julia Richter with the Joint Fiscal Office. So thinking about the way that spending is calculated or thought about in Vermont's Ed Finance formula, we have overall expenses flowing out of the education fund, right? That includes things like categorical aid, all school budgets, everything that is being paid from the state to school districts based on their budgets. There's also that technical term, education spending, which within Vermont's finance formula has a specific meaning. And that's when we take a school district's budget and subtract out all offsetting revenues. So that includes things like categorical aid, transportation aid, special education, etc. Any tuition revenues that the school district receives, those sort of things that are lumped into offsetting revenues. And when we take out the offsetting revenues, all that remains is called education spending. This is primarily about 80% staff salaries and benefits, but it also includes things like overhead costs, facility costs, tuition payments to other school districts. So that's education spending.
And that's what you're voting on your local budget, right?
So it's usually included on the ballot. There was the suspension of the ballot language in Act 127. When we think about that, homestead, how district homestead rates are calculated and can vary across districts. They vary based on the district's education spending per weighted pupil. And the reason that it's important to emphasize that per weighted pupil is because if you have a school district with few kids and a corresponding education spending level, and then a school district with a lot of kids who are very costly to educate, their education spending number is not an apples to apples comparison, right? Because they have different student bodies made up of a different number of students with different needs.
So the number you divide by is greater, can be greater than the actual head count of students.
Right, yes, so that gets into weights and how they function within Vermont's funding formula. Right, weights are calculated based on different categories of students. On the premise that those categories of students may be more or less costly to educate. So comparing education spending from one district to the next district is not an apples to apples comparison because it's not factoring in all of the nuances of that district's student body.
So if we just capped spending, we would be disadvantaging schools that had a large number of hard to educate. We wouldn't, yeah.
So, I mean, it would be a policy decision, that would need to be weighed, capping education spending, would not be factoring in the second part of the equation of the number of pupils and corresponding weights.
Okay.
Have we ever, so I guess what I'm hearing you say is that it might be more equitable to think about if we're going to cap spending,
know that we are.
I'll say we are. To cap spending per equalized pupil percentage increases. As opposed to just an overall max increase in spending in 1 year's budget to the next year's budget. It's all the choice, and you're not gonna say which one's the one better to do or more equitable, so I guess that. Have we ever, there, reframe the question, have we ever capped spending on school boards before? So this is a new territory for us.
It's not in my lifetime.
Okay.
No. No, but we've never had a 20% across the board property tax increase. This is,
For any different percentages.
yeah,
Property tax increase.
but never anything like this. And normally we roll. Now that's granted, we don't roll. We roll some things in, over a 3-year average, but that's changes in. So some of the big changes in the grand list, if you get one big development, it lowers your grand list for 1 year. Some things we phase in to stop a sudden up or down jerk in the ed fund. We try and keep it as stable as possible without big increases or big drops. But I've never seen a big drop and I've never seen an increase like this. So we're on 850. We went over that bill yesterday. It has been requested, if possible, to get it out because schools are waiting to see what we're gonna do before they decide to set their budgets. And all the rest of this, there's all kinds of discussion about what we're gonna do about this year's property tax. But at least we'll be clear that we are not capping tax rate increase at 5% if your spending's going up 25. I think that's basically all this bill does, isn't it?
Yeah, so essentially H 850 is repealing that 5% cap. You'll recall yesterday we spoke about the mechanics of that 5% cap with the latest budget data from the Agency of Education. All districts hit the 5% cap, which essentially meant all of the additional revenue that needed to be raised in the education fund would need to be raised on non-homestead. So it did away with the lever of determining the increases across property tax classes. So it repeals that 5% cap, and then it implements a new transition mechanism. That's a set discount on rates dependent on if a school district saw a decrease in its tax capacity with the new weighting formula.
This year.
Yes, using the same data for an apples to apples comparison of just parsing out what happened with the weighting changes, not all of the other factors that we're hearing about that are happening within the education fund, but saying there's this transition mechanism solely for the changes in pupil weights.
And that's. Go ahead.
So I do have, I don't think I want to do an amendment this time because this needs to move forward, but I, since somebody in the room wants to speak to what the House may or may not have considered, then welcome their body language, but I might think it would be better to have that percent decrease in future years out, the pupils in FY 26 to compare back to FY 24. And I have this written up. But I guess I'm kind of curious, maybe Julia, if you can reflect upon this, do pupils greatly fluctuate, equalize pupils from year to year, or do we expect the equalized pupils in school districts to go up or down and swing larger amounts for whatever reasons with this new formula?
So the formula uses long-term weighted ADM, which is the average across 2 years for the average daily membership. So there is a little bit of that phasing in, phasing out that the chair was referencing. With respect to swings, I think it's important to keep in mind how much the relative change of one kid moving in or out of the district, the relative change really depends on the size of that district, right? So if you have a district with 10 kids and one child leaves, it's going to be a much larger relative change impact than if you have a district with thousands of children and one child leaves. And then as for future swings, I don't know.
We know we had some during COVID because the climate refugees who came, some of them put their kids in school. And then 2 years, 3 years later, they went back to wherever they came from. And we've seen schools that just perhaps schools near those, or at least one I know of, that had a rapid decline. But part of it was its location and the climate.
Just as a quick follow-up, I could see us possibly saving on the discount and also equalizing to districts that do have swings in pupil weights if we fix FY 24, but in 26, we look at the long-term weighting average relative to 2024, they would get 80% of that difference, and then FY 27, comparing back to FY 24, if there's a fluctuation, they would get 60% of that. Either way, so we can talk about this next year if we're looking up to that.
This year.
Okay, but
If I may, there is one, I did present modeling to the House Ways and Means that was looking at changes in tax capacity using FY 24 data and FY 24 weighting formula, and then the FY 25 data and FY 25 weighting formula to see the change in tax capacity. So that was one round of modeling that I presented. And then also looking at what we looked at yesterday, that lazy S, right, with FY 25 to FY 25. What we saw was it was a hair cheaper, and really pretty much the same when looking at FY 25 to FY 25. Is a little bit cheaper to do it that way with a discount than FY 24 to FY 25 for calculating the discount. We also saw that the shape of that S curve remained It looked pretty much the same, and I can share this with Zane if that would be helpful. What changed was we had some pretty significant outliers when looking FY '24 to FY '25. Because of demographic shifts in very small school districts. So those demographic changes made the change in tax capacity seem much more significant in those smaller districts that saw a few pupils coming or going.
I don't know how much I'm gonna go elaborate, but I think we can put in the next year.
Well, we're gonna be continuing on all of this. As soon as 850 is gone. I know the House has got 2 more bills that they're working on. I know that there's a group of people, tax and joint fiscal, all working in education, all trying to figure out the dynamics here, and if there's anything we can do to the formula to keep something like this happening again, or changing it.
Madam Chair,
Yes.
if you cap spending at a given percent,
Mhm.
and say it's 10% or whatever you pick.
That's nice.
You've got towns that spend more than other towns.
Mhm.
And if the towns that spend more than other towns spend every year at the limit of what they're permitted to increase their spending, we will have put into place a formula which guarantees that the lower spending towns will never catch up to the higher spending towns. And the reason they can't catch up would be that the spending limit denies them the opportunity to have equal access to the state's taxing, which was the crystal part of the Supreme Court ruling that you can't have a system which relegates a bunch of towns to denies them equal access to the state's tax base. And that's to Senator Brock, who tells us that our system is too damn complicated all the time. This would be an example of a simple way to ignore the ruling by the Supreme Court. And people would understand that you are locking lower spending towns into the future of never being able to catch up.
I think you've described the new inequity that we've been told we're facing, which is even though penny on the tax rate raises the same amount in every town, some towns have greater wealth within them and can afford to raise their tax rate a penny or two, and other towns that have poorer, smaller towns, they don't have the financial wherewithal to raise.
Even if they chose to spend
Right.
to their own peril
Right.
of the limited amount that would be in such a cap, they will never catch up but
No.
will in fact fall farther behind year after year should the former
Right.
old towns spend at the cap level.
Well, we might be setting up a negative incentive. If you're capped at 10, we saw with the cap in the 127 cap, that you didn't have to go to report to the state till 10. Almost every school we talked to spent that extra 4.9%. So if we say you're capped at 10, we don't want to give people an incentive to increase at 10% a year, because that's way above what schools have normally increased at. And in some ways, this year schools are caught in a perfect storm with the health insurance costs, loss of ESSER funds, and new labor contracts that have to deal with 7% inflation. Inflation's down, the next labor contract won't have that much pressure. I doubt that we're gonna get healthcare costs down, but I'm gonna have this committee take the look at teachers' healthcare. And when you've got a younger, healthier population, why you're going up above what, I mean, everybody went up astronomically this year, but why they seem to be up in the top of that bracket when they should be down.
The disparities, some towns spend more than other towns because they have more money. But, or more, we're richer grand list relative to the school. But probably we have the administration and the money chairs, everyone's telling the school spend less. And if we're setting up a percentage limit on to how much you can increase, we're basically punishing the schools that did what they were asked to do
Right.
and are spending less. Now going forward, they can only spend 10% more of that.
Yes,
Lower
we've already
amount.
raised.
As opposed to someone who's been spending high, they get to increase it, so.
Yeah,
Well,
and this
further-
was,
further-
this
it
was
punishes
suggested
thrift.
by the people from Stowe yesterday. I'm not at all sure it's where we're gonna go. We're gonna keep looking at this, but right now we've got the vote on 850. And they would really like to get it out of here. So that we can move forward and schools know what the rules are gonna be for this year.
Do we have the bill? I thought it was in GovOps.
No, we have the bill. We have the bill.
Oh, yeah.
Well, they just said that,
Okay.
we have the bill. GovOps took testimony yesterday in the whole balloting thing. They did not take possession of the bill. The chair reported to me that they had no problem with the whole voting and how that is set out in this bill. So they have been heard from. And would anyone like to make a motion?
Madam Chair, if
Yes.
I might,
So, this was. Purpose, this might be unacceptable broad, suggestion was to. Insert these. So.
Okay,
And
this is, all right, we have a suggested amendment from the Speaker's office. And this is in section 4. If anybody's got a copy of the bill. Section 4A, school district budget vote. Notwithstanding any provision of law to the contrary, the legislative body of a school district may cancel the district's vote on. And the suggestion is, I can't read it,
it's a budget article
on a budget article
or related bonded.
or a related bonded article for its annual district vote. So I guess they came from the town clerks who thought this was a little
That there was more flexibility there than we might be
that we might want. So you can't just redo any article. You could only vote on a budget article or a related bond article for its annual district. So that's,
Specific to schools.
yes, specific to schools.
Can't be, it doesn't apply to libraries and.
No, those can be voted on town meeting. If you've got a bond issue out
Well,
and if it's part of the school or not,
we were trying.
you can vote that on town meeting. This is budgets only,
Budget.
or if you've got a school, but bond. Those are the two things you could
something, was that just a general?
extend the time, but just time.
I'm sure. I think the decision to postpone the decision that the towns have to make for the time that the bill calls for postponement is something we ought to do. But to begin to change, we have a system now that when we run into hard times like we're in, it's self-leveling. The pain has a mechanism that when you come out the other side, it's a self-leveling system. And I have
Everybody shares.
no eagerness to disrupt that self-leveling system and go back to where one group of towns can get more state aid than the other, because they, through gimmicks such as percentage increases that then lock things in for until the legislature unlocks them.
I am hesitant to amend, since we've been told time is of the essence. About 2:30. Okay, oh, Wendy,
Yes, I'm here.
yeah, we took a lot of testimony on 2:30 today, so I don't know. We've gotta do this bond thing, so, yeah,
I'll see you next week.
yeah,
How are we?
or not, you too. So anyway, this came from the clerks. Clerks like things very tight. But I'm weighing the risk of somebody putting some other kind of delay. We didn't give towns the ability to delay their budgets.
Madam Chair,
Yeah,
might I suggest that if we move this out of committee today, then it's gonna be on the floor on Tuesday, and should this language be still worthwhile, a floor amendment from GovOps or from ourselves would still keep us on the timeline. I just worry that if we don't get this out of our committee today,
and we will,
it is gonna be.
I mean, if we make an amendment, it's still gonna go back to the House and the House floor. And
We move it out unadulterated, if I can use that word,
Yeah, that's it.
unchanged from this committee. There's options over the weekend for people to think about a floor amendment, thus keeping us on this timeline.
yeah, yeah,
Obviously, everybody can always come back around and then another.
I mean, it would make more work for the clerks if somebody just to do a bond for city hall improvements and move them out 3 days.
There are just a lot of,
Yeah,
there are a lot of school boards that if they hear that it didn't move out of this committee today, it's gonna give the signal that they need to even have more chaos and pause on their actions. So just to keep things going, I would make a motion to move H 850 out of committee without amendment.
so Senator Chittenden has moved that we vote to approve 850 as presented to us. Senator McCormick.
Can I have just a clearer explanation of why, of the urgency? We're telling towns that they delay their school.
If we don't move it out today, then we're coming back on February 20th. And then we would move it out on the 20th to then warn it for notice the 21st, which would be action on the 22nd. With amendment, it goes back to the House. That brings us into the week of the 26th, 27th. They then also get to the governor for signature all before March 5th. So as I look at this calendar, I mean, these school boards are in not chaos, but in great uncertainty as to what to tell
I
voters.
don't take testimony from the side or questions. If you have a question, you can write a note and pass it to Senator Chittenden. Or if you represent the town clerks, I can have you speak.
My only point for the town clerk's amendment is it can still happen on the floor, and that way we keep on our schedule.
I think we need to get it out. I think towns need to know that it's not getting tied up in the Senate, that the 5% cap is gone. I'm hoping we'll have 2 for you today. You can hang around for a couple of minutes.
Yeah. And I'm waiting for S311.
Okay, so Senator Chittenden has moved that we approve AH 850 as it was sent to us. Waiting to get a chance for a question from the side. I'm getting a lot on delay the vote. It will be a burden on towns. But I'm not sure where, I'm sure.
Did you
you're
say
getting-
delay the vote in here or in towns?
No, they want us to not pass H 850 right.
But I think it'll be worse in terms of confusion if we don't vote.
Yeah.
It would be worse for the towns that are expressing concerns right now.
And I'm looking at the danger of having towns delay their town vote or a bond for a new fire station vote, that would be difficult for the clerks. But I know, Julia, do you have,
I can't speak directly to that. I would defer to legislative council in terms of, if which districts can and cannot delay a vote with this language.
okay, Kirby, do you have a,
Kirby Key Legislative Council, I would need to consult with Tucker about that.
okay,
for
because that's more of a gov ops.
Yeah,
Yeah, I mean, right now, we've said, and we have money to pay for moving school votes forward. School budget votes. And I haven't heard any movement. I know the clerks would like it tight, but I think it's more important to
Sorry.
to get this bill out today. And then we hear a really compelling reason to do it, we can amend on the floor.
So, Madam Chair, that we're reading,
Senator Chitney's gone, so you kind of get your, see if you can take the message from the side. Okay,
so what we would be voting on is the plan that the House has sent us
yes,
to give towns the opportunity to delay their school budget votes. While solutions are looked at and folks have a chance to make some adjustments. And we're not putting any caps on school spending.
Not doing it.
And that's what we're voting on.
yes, we're making it clear that there is not a 5% cap and we cannot put. a
Well, that was the 5%
Yes.
weighting thing
Yes,
from
from last
a
year.
previous,
That's what this is correct,
what we trying, that we were worried about. But
yes.
we're not putting any
No.
different caps on spending.
No, we are not putting anything. All this bill says is the 5% cap is gone. The impact of the new weighting will be phased in over a 5-year period. And, for those schools that lost based on a percentage will equal a penny on your tax rate. And, we're going forward from there. We have $500,000 to cover the expenses for the towns in having to reprint their ballots and hold the new election.
So we're basically voting to concur with what the House is.
We are
sent to
voting to
us.
concur with the House.
And
And I've lost them.
with the knowledge that should anything else crop up between now and when it comes up on the Senate floor, that has to be dealt with.
Mark, can you take the?
I hope you can read it, right? Thank you.
So. If you don't.
Oh, I'm sorry, it's like your simple stuff.
We can amend our.
Today, amendments.
That'll send it back to the House. and the
Concern we're
House
not doing
floor.
today is it's gonna send a signal to all school districts that this
Well, it's
isn't
gotta go
gonna
through our-
happen. I think it is.
It's gotta get voted out by us.
Mine
If
worry
if somebody can convince us the amendment would slow this down, because we were told it's gotta be out there, so.
It wouldn't even slow it down because we could do it second or third.
Finger on. So,
Okay.
You know what I
But
mean?
then it has to go back. to
There's a
the
lot
House, So it's another
of
day.
communities and districts.
No, I think it does
Okay.
delay, what, so if you roll it out here,
We're,
it goes to the floor.
and I pushed our.
And then we just do it.
We can amend on the floor.
Severely.
But then we have to go back to the House.
But it would anyway, whether we have the amendment.
No, because we're concurring with the House, so we will go back.
That's.
Oh, I see what you mean. Well, if we're message.
You put whatever you want.
Yeah.
There's no.
We can do all that.
Per se.
Okay.
So wouldn't really add, we just add message.
You need to have.
That, if somebody can get us,
They have this to know.
yeah, somebody can get us.
If you do this,
Why we
that pulls
should
the
make
rug out.
this change.
I'll make that.
Okay,
Sure.
okay,
I can. only
Senator
speak-
Chipman is here, Senator,
Richard move to concur with this bill as it arrived from the House,
on amendment.
but happy to withdraw it if you have new information from.
No, the pro tem thinks he will find us some witnesses, and if the witnesses convince us that, this is a good thing to do or a necessary thing to do, we can do it on the floor as an amendment. But that will send the message that the Senate is concurring with this. And then we'll get some of the clerks in here and find out why we might have to amend it. Okay? And since the suggestion came from the speaker's office, I'm assuming there'll be no roadblocks. Okay, we have a motion on the floor to concur with the House on H50. To vote it favorably as it was presented to the committee. Is there any further discussion? If not, all those in favor say aye.
Did we hear, there was some question being brought to us.
It got put over there. I never saw it.
So.
Okay, so this, just for the record, it reflects a lot of what we're hearing in the notes, that we believe there is a time sensitive nature to this, and we're hearing from others.
And we'll hear from the clerks or whoever's proposing that amendment before third reading so that we can make an amendment if we think it's necessary. I'm not comfortable just having a note handed to me by the pro tem to say, adjust your bill. I want to do it.
Here's what I might say as advocates on any action on this. This still allows for over the weekend for you to continue to do so, to lobby for changes, amendments to the floor. I just, as the sensitivities I have to the school districts in my constituency, I want to send a clear message that this is the path that's moving forward so they can continue on what's been communicated in multiple fronts.
They've asked for certainty.
I'm sure the clerk doesn't know whether we've taken a vote or not.
We have not taken a vote yet. We have.
My guideline.
That got interrupted.
Yes.
The discussion, I'll be voting yes to keep the question. That's, my yes vote means keep the question open.
That we will consider. We'll put a space on Tuesday, first thing, and we will go. So all those in favor say aye. Aye. Opposed say no. I'm calling that 5-1.
6-0.
No, 6-0-1.
Yeah.
Got that. Okay, so who would like to report that?
So volunteer.
Sure.
Sure isn't too complicated.
It's never complicated when you start, it's when the questions. Thank you. Okay, we will be back. Okay. All right. We are now, we're gonna vote out, I hope, 199, we have the amendment. That's his sheet.
Very much.
And
I
I have the amendment here in my little papers, which I need to clean out for that. Here. Markman.
Yep.
Take that, don't forget that done. We've done this.
But
Yes,
I don't see a copy of the amended language on our website. Do we have that anywhere? Yeah.
that's what I'm looking for. We had it should be on the website after the video. And it was changing the name of the, remember the treasurer could just have anybody take over their duties. This says they can take over their duties if it's approved by the board and, approved by the board and
I see.
they cannot, delegate their responsibility.
It was here for yesterday, Tuesday, that
Yeah.
travel. So it's Friday afternoon, I feel like I want to help move things along. I would make another motion to move draft number 1.1 of S-199 as an amendment to the bill.
Okay, Senator,
Did I do that wrong?
Senator Chittenden has moved that we amend. No, that's the Medicaid. 199 with the amendment,
1.1
1.1.
February 15th, 2024 at 12.
That was as presented to us by Maria, I believe, yesterday. It just tightened up the wording on the treasurer's responsibility in delegating them. So they can delegate the duties to an accounting firm, but they cannot delegate their responsibility, and they have to have permission of the board to delegate any. Okay, so Senator Chittenden has moved. Is there any further discussion? If not, all those in favor say aye.
Aye.
Opposed say no. I'm hearing that as 601.
Senator Gray is not here. I'm gonna try to step in, and now I would move that we approve the bill
As
as
amended.
amended.
Okay, Senator Chittenden has moved that we approve S 199 as amended. All those in favor say aye.
Aye.
Opposed say no. Seeing that is 601. Who would like to report these? You can report the 199. I'm doing the 850. Okay. So. If we can, that is it for the agenda today. We're ahead. But anybody that has any thoughts on what we can do about the property tax increases, get them to me.
I sent you one last night. And we'll-
Yeah,
Do the thing that nobody's talked about so far.
spending less.
Exactly, reduce spending.
Well, that's how we're trying to, the question is,
It's
how
so
do we,
simple.
how do we make schools do that?
Town by town by town,
Yeah,
under the proposal.
But it's a both and. We're asking them to do their part and we're trying to provide relief for some of our changes, but
Well, again, it's that question of, that after this initial flurry here is over, whether or not we want to take another pass at saying we really need to revise all these systems and make them work together, because it's a major problem. Whether we need another Blue Ribbon Tax Commission, we tried it a second time and it was not particularly successful at all. The first one was, and unless we deal with all the taxes together, we're gonna continue to be back here with nonsense like this every 2 years.
well, this is the first big role. In 20 or something, years.
Perfect storm every 2
Okay,
years.
Jane, can you get the original copies of those two bills? And with some sheet.
I just forwarded you another email, Tim Manish, about another person to hear from the agency that on common ledger of accounts and just
Okay,
Bill Bates is available.
okay,
You were asking for.
I can ask, I don't have jurisdiction, but we can ask.
Yeah, good point, maybe I can bring this up.
Anyway, I need to sign something, right? Yeah. This is what I thought. And, I'm just reading for all the changes.
Okay. That one is the one.
No, I'm not,
This is 199.
I'm not doing
We
that.
want 850. Does that have any influence?
No, not at this point.
Okay.
Then it does have to be.
Yes. And who is the reporter?
Right.
So you. But they're signed there, the commission there.
Okay. That one, I'm not good. Thank you. Not you're gonna be right upstairs. Okay,
Going offline?
I think we can go offline.